All right, welcome. Today, we're going to tackle one of the most common and honestly most missed challenges you're going to face on the wards: how to recognize and manage delirium. This is such a high yield topic, and getting good at it will absolutely change how you care for your patients. Okay, let's dive in. So let's start with a number that should really get your attention: 30%. Get this, nearly a third of all older hospitalized medical patients will experience delirium. It's everywhere. And if you aren't actively looking for it, I promise you, you will miss it. So here's our game plan. First, we'll talk about why delirium is a silent emergency. Then we'll get into the nitty-gritty of spotting it. After that, we'll play detective and find the cause, lay out a solid management plan, and wrap up with prevention and what happens long-term. Okay, part one, the silent emergency. We call it that because delirium is so much more than just a little confusion. It's a full-blown medical syndrome, a sign that something has gone very, very wrong. And this really shows you what the stakes are. Delirium is a huge predictor of bad outcomes. We're talking increased risk of death, longer, more complicated hospital stays, and for a lot of patients, a permanent hit to their cognitive function. This is not just a symptom, people. It's a medical emergency, and it demands our immediate attention. All right, let's move into our next section, spotting delirium. This is probably the most important clinical skill here, because if you can't recognize it, you can't treat it. So how do we get good at this at the bedside? The official definition really gives us all the clues we need. The number one keyword is acute. This isn't some slow decline over years. We're talking hours to days. The other core features? A major disturbance in attention. The patient just can't focus. And a course that fluctuates. You know, they might seem totally fine in the morning and be completely out of it by the afternoon. Now, this is a huge point of confusion for so many of us: delirium versus dementia. Onset is the big giveaway. Delirium is acute. Dementia is sneaky, it's insidious. The course? Delirium is a roller coaster. It fluctuates. Dementia is a slow, progressive decline. And attention, this is key. Attention is one of the first things to go in delirium, but it's often okay in early dementia. So here's the bottom line. An acute change is delirium until you've proven it's not. And here's a clinical pearl that will absolutely make you a better clinician. We all picture the agitated, yelling, hyperactive, delirious patient. But guess what? That's not the most common type. Far more often, you're going to see what's called hypoactive delirium, the patient who's quiet, withdrawn, maybe a little lethargic. Everyone just thinks they're tired or depressed. This is the patient we miss the most. So how do we put all this together? Your new best friend is the Confusion Assessment Method, or CAM. It's simple, it's fast, and it works. For a diagnosis, you need two things to start. Number one, an acute onset and fluctuating course, and number two, inattention. Once you have both of those, you just need one more thing: either disorganized thinking or an altered level of consciousness. That's it. It takes minutes, and it's really the standard of care. Okay, so you've used the CAM, you've diagnosed delirium. Awesome. But your job isn't done, not even close. Now the real detective work begins, finding the cause. Remember, delirium is just a symptom of a bigger problem. And the first place you look is always, always, always the med list. This quote says it all. Drugs are the culprit in about a third of all cases. We think of psychoactive drugs, of course, but don't forget about over-the-counter meds. Even normal drugs at therapeutic levels can be enough to push a vulnerable patient over the edge. Besides meds, this is your high-yield checklist. For every single patient with delirium, run through this list. Is there an infection, like a UTI or pneumonia? Are they dehydrated? Are there electrolytes all over the place? Are they stuck in bed? Or are they in withdrawal from alcohol or benzos? These are the usual suspects you need to find and fix. So, you've got a working diagnosis, and you're hunting for the cause. Now let's talk about the management plan. You really need to think about this as a clear, two-pronged attack. The principle here is really simple. You have to do these two things at the same time. You go after the underlying cause, treat the infection, fix the electrolytes, stop the bad drug, and while you're doing that, you provide intense supportive care to protect their brain and their body while they get better. And let's be super clear, this supportive care is not fluff. It's first-line treatment, and it's almost all non-pharmacologic. We're talking about simple things that are incredibly powerful. Having clocks and calendars around, protecting their sleep, getting them up and moving, making sure they have their glasses and hearing aids, and treating their pain. And please, for the love of all that is holy, avoid physical restraints. They almost always make things worse. Now let's talk about medications, because this is where we can really do some harm. Medications are not a treatment for delirium. Let me say that again. They do not fix delirium. They are a last resort for when a patient is so agitated that they're a danger to themselves or to the staff. It's about keeping everyone safe so you can do your workup. And if you absolutely have to use a medication, the mantra is start low, go slow. A tiny dose of an antipsychotic like haloperidol, say 0.5 to 1 milligram, can really help. And here's a major pitfall to avoid: benzodiazepines. Unless you're treating alcohol or benzo withdrawal, drugs like lorazepam will almost always make the confusion worse. Just avoid them. And now for our final section, the long view. Because honestly, the best way to treat delirium is to stop it from happening in the first place, and we also need to understand what happens to these patients down the road. Remember all those non-drug interventions we just talked about? Well, they're even more powerful when you use them for prevention. Putting together a strategy that focuses on these things, protecting sleep, keeping patients mobile and hydrated and oriented, has been proven to dramatically reduce how often delirium happens in high-risk patients. And this, right here, is why it all matters so much. A patient doesn't just get over delirium. An episode is a massive stress test for the brain. It's an independent risk factor for death, and it can hit the fast-forward button on an underlying dementia, or even bring one to the surface that wasn't obvious before. The brain might never go back to the way it was. So I really want to leave you with this thought. The next time you're on the wards and a nurse tells you, Mrs. Smith just isn't acting right today, this is the question that should immediately fire off in your brain. Don't just brush it off. Think about what we covered, pull out the cam, and start that detective work. You might just save her brain.